For the people skipping the class, I'll go ahead and record it. Maybe. No, there's three. Stacy, Emily, and Lauren.
Emily's sick.
And that's an excuse why?
Did him at least sick.
Okay. Criteria for, or standards for pulmonary function testing have been created through the American Thoracic Society. You can see this has gone back numerous times and they've updated it periodically. The most recent one looked at spirometry in children. Actually, I think there was one after that, but periodically they go and just make sure that the technique that they're describing is the most appropriate mechanism to do it. This is out of Egan. I think you should memorize this. That'd probably be wonderful. Okay, I'm kidding. But it starts off with the same spot we've started off with being looking at the ratio. And is the ratio below the lower limits of normal? If yes, then you can go ahead and look at the vital capacity, going on to total incapacity, and basically classifying it not only as a normal test, but also looking at diffusion, whether or not there are some other diseases that could fit into that. I'm not going to ask you to do that, but you should have the basic idea as far as how to interpret pulmonary function tests. As far as the process of doing these testing, kind of starts with making sure that the equipment has some kind of validation and has performance criteria. And this is done more by the manufacturer than by us. But in selecting pulmonary function equipment, it makes sense to have some product that has actually been validated. We're going to do, though, quality control on this product on a daily basis to evaluate whether or not there's leaks in the system, to evaluate that the spirometry mechanism, how it's measuring spirometry is accurate. We'll then do some patient maneuvers, we'll do some measurements, we'll verify that these measurements are acceptable and reproducible, and I'll explain what the difference in between those two are. And then go ahead and compare it to a reference value to interpret, and based upon that, some clinical assessment will be made, and that feedback also should come back to the technician as far as the physician saying, you know, that I'm noticing that I see this problem reoccurring, we need to address it. And again, quality assurance should be some mechanism that makes sure that the test quality is there. Could be pre-test, you want to make sure that the appropriate calibration of equipment and the collection of data on the part of the patient is appropriate. And one of the big ones that involves is the measurement of height. Not asking the patient how tall they are, physically measuring their height, because we all know that we overestimate our height. It's just kind of a natural thing that we end up doing. And for the same purpose, measuring their weight. Even though it's not part of the predicted values, it is something that should be reported. Who's ever doing the testing should have some prior training in pulmonary function. This is one of my pet peeves with medical assistants in physicians' offices. Often have very minimal training in pulmonary function, and a lot of the handheld, a lot of the small spirometers, for those of you who I've met with, they give grades and say this is a good test or this is a bad test. And unfortunately, what a lot of physicians' offices do is they turn those off, defeating the entire purpose. So take that as it is. Then as far as the testing, there's quality as far as the appropriate instructions that are there. Looking at the appropriate reference equations, and in post-testing, looking at the interpretation being appropriate for that diagnosis. So let me talk a little bit about the different kinds of spirometers that you're going to encounter, and this is probably the deepest we will get related to that. Two different types, one are volume displacement and one are flow sensing, and these basically are translated also over to mechanical ventilators. The gold standard, the most accurate, is the Collins water seal spirometer, and it uses a device called a chymograph to be able to measure this value. It is actually the device that is used to test other pulmonary function units. So it's kind of the bench gold standard. Beside the water seal, other volume displacements are the dry rolling seal, a bellows type and a diaphragm. The good thing about these is that they directly measure volume. They're not measuring flow and translating into volume. It's directly measuring volume. It's a relatively easy operation, low cost, but the big problem with them is leaks. If the system has a leak someplace, it's going to give you inaccurate readings. The other problem with them is they're pretty large and bulky. It's not something I'm going to be able to take to a patient's house. It's not something I can transport around the hospital easily. The water seal literally has water, which means I have to change that water periodically or it's going to get funky. That's a medical term, by the way. And then you need a computer to do the calculations. Otherwise, we have to manually calculate what the FEF 2575, what the FEF 2200, 1200 is, what's the peak flow, etc. Here's a Collins water seal, and you can see the water inside, and basically it's a big drum filled with water where another smaller drum is inverted within it. So as the patient, let me get my pen here. Where are you? Seriously? There we go. And watch, the pen is white now. But as the patient exhales, they end up filling the inside of this chamber. So when it pushes the drum upwards, that moves on the pen. This is the chymograph. And this is spinning around, and as it spins, when the patient exhales, it measures the volume directly. That actually is the gold standard that is there. So those water sealed, again, we want to check the water level. We want to make sure the speed of that drum turning is appropriate. And they should be calibrated daily and the water changed weekly for that matter. This is a wedge spirometer, kind of a similar idea, measuring volume directly. As the patient exhales, they change the size of this accordion on the inside, which then changes the pen, or changes the position of the pen on the paper, and measuring a volume time curve on that device. And again, got to do manual calculations to determine what the vital capacity is, what the FEV1 is, etc. Here's another wedge spirometer that is there, another different type. And this is the dry rolling seal. There's actually a drum on the inside that has a small rubber silicon piece that as the patient exhales, it actually pushes that down. And there are some ventilators on the market that actually utilize this kind of a mechanism to monitor volumes with. These are our 3-liter syringes we're going to use to test any kind of spirometer, really, not just the volume ones, but the top one's a 7-liter, good God almighty. Usually it's a 3-liter syringe that we end up using, although there are smaller ones that can be measured for smaller volumes. And when we're looking at a volume time curve, you should see a constant volume. With the face of a leak, you're going to see obviously some loss of volume there. Flow sensing spirometers, on the other hand, use something to measure flow, and from that they integrate that flow into volume. If we know that instantaneous flow, we know volume per unit time, therefore we can figure out what the volume is. Some of the different types that we'll go through, I'll go through these individually. First of all, the pneumatacs. These are pressure differential flow sensors. It's measuring flow on either side of a resistive element. So as the pressure drops across there, if I know the resistance of that and I'm measuring the 2 points of pressure, I know the instantaneous flow that we end up having. This is how a lot of ventilators measure their tidal volume, is that they use a pressure differential pneumatac. It's the most common mechanism that it is. So here I have a known resistance in the center. I have the ability to measure pressure on either side of that. I can know what the instantaneous flow is. A second type is a Wright respirometer, and you've seen these. We used them in class way back in 1050, all those years ago. Well, yeah, it was a long time ago. We were talking, I think, about Module D, pulmonary function testing. No, we're talking about Module B even. Wow, it was even older than that. But what we end up having here is basically a rotating vane that spins and causes these gears to move. And it's an actual mechanical mechanism that we end up having, so we can then go ahead and read out what the volume is. The downside to these is that they're only accurate when flows roughly between 3 and 300 liters per minute. So you would never do a forced vital capacity because the flow is much more fast than 300 liters per minute. In most adults, their peak flow is way above that. But it loses accuracy, and it can actually damage the device if it's used for that purpose. Slow vital capacity, no problem. Forced vital capacity, big problem. Heated wire anemometer is basically another mechanism. I heat a wire, and as gas passes through that tube, the flow is directly proportional to how much the wire is cooled. If you cool the wire a lot, there's a high flow rate present. This is how the Draeger actually measures volume on that expiratory flow sensor. Then there's a Vortex-Shedding Device that basically uses ultrasonic waves. And as these waves are emitted across, there's some struts that are in the path of the gas that makes it turbulent. And the degree to which that signal, that ultrasonic signal, is disturbed is directly proportional to the volume. This is how the servo eye measures tidal volume. So, kind of covering them all. Good news about the flow sensing, they're really small and portable. Internal computer does all the calculations for you. You can do bidirectional flow, so I can do not only a forced expiratory maneuver, but a forced inspiratory maneuver also. And as you see on the ventilators, they can be used to continuously monitor volume and calculate out minute ventilation. Downside, sometimes they're a little bit more temperamental and difficult to operate. They need frequent calibration, and moisture is huge, causing problems. As you well know with the Draeger, that's why we put a filter on the expiratory limb. That heated gas will actually collect on the flow sensors and can interrupt volume measurement. They also have problems with gases other than air and oxygen, so heliox causes all kind of issues with them. And some accuracy problems at extremely high and extremely low flow rates, but for the purposes of our lab, of our pulmonary function lab, they usually work out quite well. We said that spirometers should be calibrated daily, and those ones that are volume displacement style should be leak tested. What we're looking for is a plus or minus 3% accuracy or 50 milliliters, whichever is larger. We're going to do these measurements, these spirometer calibration measurements, at 3 different flow rates, usually one very slow, one very fast, and one somewhere between the two. And then we would go ahead, and if we're using a 3-liter syringe, that plus or minus 3% would be 90 cc's, which would be 2.91 to 3.09. So that 3-liter syringe should come within that range of measurement when we're testing it. As far as doing PFTs, we want to make sure, again, the patient has been notified to stop medications, to stop smoking, and more often than not, you want to, and this usually is done with whoever books the appointment, we tell them it's going to take, an hour and a half or so, so block that amount of time out, and yeah, don't eat a full meal, because we're going to be nasty to you. I don't care that you know these times, but roughly we don't want them to have a dose of any kind of medication just prior to that. Does anybody know what that last medication is? Hasn't been on, I don't know why I even have it on the slide, it hasn't been on the market in probably 25 years. It was a medication called Bronchosol. Want to ask one of your clinical instructors about Bronchosol, and they'll just go, "Oh my God, it's an oldie but goodie." Actually, Metapaternal, I think, is pretty much gone. That's Alupent. I don't even think that's available as an aqueous anymore. So, patient prep, you want to make, again, measure their height and weight. Patients who don't have legs, one of my buddies who was doing pulmonary functions had a double below the knee amputee. So how tall were you? A better measurement is arm span. Fingertip to fingertip is a real close approximation of your vertical height. Height should be measured without shoes. Seems kind of simple, but that's the centimeter or so can distort it. And we talked about the predicted values prior. Relative contraindications to pulmonary function testing. If you're seeing somebody in the lab who's having hemoptysis, it could be an issue, but again, we want to be able to just document that. Shouldn't see anybody who's got pneumothoraces. Shouldn't see anybody who has unstable cardiovascular status. Hopefully those aren't the cases. Recent eye surgery, just simply because you're building up intrathoracic pressure with that forced exhalation. You want to have some problems. If they're nauseous or dizzy, again, these are relative contraindications. And we said about a full meal. So most of them are pretty logical as far as the contraindications. Keep the explanations as simple as possible, especially with the elderly. They get confused quite easily. It doesn't hurt, but it requires a lot of effort. And that every test is probably going to be repeated multiple times. So it's not that you're doing them wrong, it's just that we need to have multiple measurements. Should be sitting with their chin up, feet flat on the floor, loose clothing, so they're comfortable. It's nice to be able to not only explain the procedure, but demonstrate to them what you're expecting back from them. You can stop the oxygen for the test maneuvers if they're on continuous oxygen, but most of the tests you want to do without the oxygen flowing. And then coaching is huge. And we're going to be able to just by tell from the graph, again, if there's some problems that are wrong. And the new terminology is blast, not blow. I don't know why they changed it, but sir, will you mind just blast that out of there? Take a deep breath as deep as you can and blast it as hard and as fast as you can. 3 acceptable maneuvers are what you're looking for, no more than 8. 2 trials are reproducible if the 2 largest vital capacities are within 0.15 liters or the 2 largest FEV1s are within 150 milliliters. So that's the range that we want to see as far as reproducibility of a test. If they're reproducible, they're valid tests. And we can use that test then in our for our interpretation. 150 milliliters.
So that changed from 0.2?
Yeah.
Okay.
Yeah, that was, do you have 0.2? 0.15. That was one of the changes that the, I think that's why I have them circled.
Oh, okay.
One of the more recent changes from the ATS.
And that can be 100 milliliters if the FEC is less than
Yeah, if you got somebody whose FEC is less than a liter, ouch. You probably will never get 150 difference between them, so they give them a little bit more leeway for somebody with small FECs. Okay, there are a couple of things that says whether or not, this is telling us whether our tests are reproducible. We also need to determine if the test is acceptable. There's certain things that occur that make a maneuver useless. And these are the values there. A good start of the test, meaning there's no hesitation. There's hesitation there, it's not going to be accurate. And there's something called extrapolated volume that we can use to evaluate this, and I'll talk about that in a second. A good effort, and that's basically a judgment call on the part of the tech who's doing the test, wanting to make sure that the patient's giving their best effort. Coughing, especially during the very beginning of the test. Towards the end, it's not as much of an issue, but certainly in the very beginning, you want to get a valid peak flow to be able to see it. We should see on that expiratory flow curve a nice round or nice straight line as they exhale, not something where I'm seeing the flow rate change all over the place, usually as a sign of coughing. And there's a minimum exhalation of 6 seconds unless there's a plateau that has been established. And again, in most younger people, you would end up having that plateau established long before 6 seconds occurs. But we want to basically have a maximal effort to be able to get the best value there. This is the back extrapolated volume, and it's kind of a technical thing that I'm not going to worry that you know about. If you ever take your CPFT or RPFT, come back and talk to me and we'll cover it again. But it's basically saying, is the starting point the appropriate starting point? Here I ended up having what looks like a little hesitation to start with before they finally started to maximally exhale. If you draw a slope of that line back, you can quantify how much volume you're theoretically losing with that hesitation. That doesn't make entire sense, that's okay. But this is basically saying, was the test started at the right moment? Was the collection of volume done at the right, at the optimal time? Yeah.
So are you saying that that one is not?
That one's not. So this is kind of how they do the grading. I'm looking here at the hesitation. I'm looking at a patient effort getting a maximal flow. I'm looking at flow variability from a cough. And I'm looking at early termination. Here, I'll mark those down for you. Hesitation. Good effort. Peak flow. Variable flow or cough will generate those. And early termination. Okay. All right. And this is basically how they do the grading. They're saying that a B grade would be something where I end up, you don't need to know the gradings here, but I would like you to know those 4 things I just talked about. But you're saying how much of a variance you're seeing in the FEV1 values. And a grade of F is basically there's no acceptable maneuvers, and this is kind of why it pains me to see physicians' offices turning those values off. An A value means that I have at least 2 acceptable maneuvers going on. And again, you can watch the messages as they're reading out. A lot of them will have coined phrases like, don't hesitate, meaning I'm seeing a back extrapolated volume greater than 150 milliliters. Blast out faster. The point to getting to that top of that peak flow is too long. I'm not seeing it immediately. Blow out longer, meaning I'm not seeing the maximal effort because I have terminated earlier. Blast out harder, peak flows are not consistent. And a deeper breath means I'm not seeing the FEC repeatable. And when we see good maneuvers, we're going to see a good test. So those are kind of common phrases that a lot of these portable spirometers will end up utilizing to tell the tech that you're on track with this patient. You may want to put a star by those, because that might make a good question. Yes, Shannon. I mean, you can't see it. Like I care?
Is it online?
I'll put it online. All right. When you're seeing deteriorating flow rates, you may have a situation where basically your testing is inducing bronchospasm. And that's something that you need to document in the process and obviously treat the bronchospastic episode. We're going to report these at BTPS. We're measuring them at ATPS, which means I have to have a conversion factor there. The computer does that naturally, but it means that we have to know what the barometric pressure is and what the room temperature is that we're doing these measurements in. Okay. ATS says you can use the FEV6 instead of the FEC. After 6 seconds, you probably got a maximal effort out of that. There's not going to be a huge amount of difference in most patients. And it also then shortens the testing session and doesn't really drain the energy on the part of the patient. If you truly have obstruction, you'll see it with the FEV1 to FE6 ratio, as you would with the true FEC. All kind of spirometer predicted values that are there. Again, Crapo was the one that was measured in Utah in the Mormon population. But there's a bunch of them out there that you can, and usually a pulmonary function lab, the medical director of the lab will say, we're going to use this. And it's just kind of an accepted process.
Are they mostly similar?
Yeah, they're not too far off as far as that. There's actually, this is actually an older slide. There actually is now one specific for various populations that are there. I've actually even seen them for Pacific Rim and for Indian, not American Indian, but Indian. We know about the classification of severity: mild, moderate, severe, very severe. It's an old slide because it's got the at-risk there. It's no longer there. And I think that's it. Wow. Remember those, Beth?
I do.
Look at those bell bottoms.
The polyester.
I kind of like the pop collar.